ये फोन मध्ये आहे का? नहीं आ रहा है क्या स्क्रीन?
Yes. We have Anjali and DIAP, Palghar Academy. We have all these people, Dr. Suraj. Participants.
सूरज I don't know.
So please,
Yeah.
describe them. So DIP is there.
We can see the 2-month-old screen.
Yeah.
1 year, 2 months. Yeah.
Anjali, your screen will work next time. Your unit today we can do it.
No
Your-
problem at all.
This phone is yes. Only number.
Good evening, everyone. I am presenting this Thursday clinic. Myself, Dr. Suraj. Just 1 year, 2 months old mention, first by birth order, born out of fertility and second marriage, resident of Govaldi, alien from Turkey, Muslim by religion, Shah by community, was brought by parents with complaints of vomiting since 20 days, stool since 20 days, swelling over bilateral lower limb since 18 days. Child was already 20 days ago. Then he developed vomiting, which is non-projectile, non-bilious, 5 to 6 episodes a day, mostly post-meal, containing food particles and water, followed by loose stools, which is semi-solid to watery, 8 to 10 episodes a day, initially with black tarry stool for 3 to 4 days, then blood with small amount of streaked, followed by greenish blackish in color, not associated with the passage of worms or worms in stool. Then child develop bilateral lower limb swelling, initially up to ankle joint, then progress to knee joint, lateral progress to involving bilateral lower limbs till thigh, pubis with penile shaft. Also, mother noticed swelling of the upper limb with periorbital puffiness. There is an associated history of decreased urine output since last 5 days, lethargy and decreased urine output since last 5 days, and history of outside food consumption. For the above complaints, child received treatment in the form of oral medication on OPD basis from private practitioner, but not relieved symptomatically. Then child was admitted for 5 days, received IV injection, no IV fluids were given, as told by mother, but not improved, hence referred to tertiary center and brought here. Currently, the child is admitted in ward and the frequency of blue stool has decreased, and the child has improved symptomatically. There is no history of fever, irritability, bottle feeding, unknown drug consumption, no history of similar complaints in the past or in the family, no history of fatigue, bleeding from any side, no history of jaundice, no history of abdominal distension, no history of breathlessness, or there is no recent history of consumption of any Ayurvedic medication. With past history of at the age of 1 year, child admitted for 3 days in view of fever, cough, and increased work of breathing. No to support required. IV injection and naps were given, and discharge on oral antibiotics for 8 days. ANC history, uneventful, supplements taken, calcium supplements taken, in TT injection received, 6 ANC scans done, which is told to be normal. There is no history of thyroid disease, hypertension, GDM, no history of blood transfusion. Birth history, uneventful, full-term vaginal delivery, 2.5 kg. No history of NICU stay. Discharge on day of life 3. Breastfeeding started immediately. Birth vaccines received. There is history of neonatal jaundice on day of life 5. Gave Ayurvedic medication for the same. Child is immunized till 3.5 months. That partially immunized. Developmental child is appropriate for the age. Dietary history of child was exclusive breastfeed on demand, around 7 to 8 times a day, which each feed lasting around only for 5 to 6 minutes, then shifted to another breast, feeding regularly 6 to 7 times in a night time. After 6 months, complementary feeding started. In the dal water, smashed banana and apple started along with the breastfeeding. Still, child is predominantly on the breast milk. There is a calorie deficit of 417 kilocalories and protein deficient of 8.5 gram. Socioeconomic still child belongs to lower class by modified Kupuswamy scale.
second slide and no problem. नाही पण तो याला कनेक्टेड नसेल त्याच्यातनं त्यांना ऐकू येणार नाही त्याच्या
That mic is the best. Their mic. इसमें से उसमें जाएगा फिर जाएगा.
नहीं इसमें से नहीं जाएगा
उसमें से जाएगा.
Hello, Anjali, can you hear?
That's the best thing.
Yes, Rajesh.
Very clearly.
Yes.
Hello.
Yes, I can hear you.
Yeah, okay.
ये अच्छा रहेगा सबसे.
हाँ वो यही पर वो मैं
मुझे लग रहा है. यार यहाँ से बोलना पड़ेगा.
Is this better? Or is the same? Anjali.
This is echoing a bit.
Okay. Okay, so tell us what are your thoughts on this initial history? So this child starts with vomiting followed by loose motions. So tell us your thoughts on that. Then we will take it further.
Like a dysentery kind of episode, loose stools containing blood and vomiting. Initially, it must have started as a an acute dysentery.
So is it a viral gastroenteritis or is it a bacillary dysentery? Bacillary dysentery starts with vomiting 5-6 times a day. Is there any difference between viral gastroenteritis and bacillary dysentery in the clinical story and what you find here? What is not fitting in for a viral gastroenteritis?
If we pick up something unusual in patient and then focus on that. Maybe the black tarnish stories. When did you see black tarnish stories in intestinal infection? Did you see that in bacillary dysentery? Did you see in viral diarrhea? So what do you make out of that? So vomiting those stools, etc. all right. Even on day 1 or day 2, the moment you were told that there is a black tarnish stool, you should have noticed this is something unusual. And start thinking what that conveys to. Taking very thoughts on that. Just give a thought, doesn't matter. I'm sure you're seeing that tarnish stool, not in this situation. Why don't you come up? Please come on, please come on. Please come on. Please come on.
Blockbuster stools basically very not so upper GI fluid.
Excellent. So upper GI dream. So now, why has he had an upper GI dream? He's coming with vomiting those stool. When is an upper GI involved? So anatomy some looks to be upper GI as well. Okay, whether it started from upper and went to lower or vice versa, we will look at that. But there is an upper GI dream, right? Then what are the causes of upper GI dream? So think in different ways. Okay, if you cannot get an easy answer to this syndrome, start thinking when did you start last upper GI dream? Give a thought, doesn't matter.
Esophageal varices. So might be like on side.
What else? Like upper GI bleed, you said esophageal varices. What else? 3, 4 common causes of upper GI bleeds.
Not in this issue, but like
Yeah, so ulcer. Then,
multiple episodes of vomiting which is associated with retching.
so Mallory-Weiss syndrome, so multiple vomitings. Okay. What else? Not common, but sometimes some malformations, etc. Right? Any swallowed blood? Epistaxis and swallowed blood. Okay. Drug induced. So now, can any of this fit in here?
In the background of vomiting, maybe. The background of vomiting and
So again, for it to cause tarry stools, how much ml of blood would you need? Like 2, 3 ml? More or less? So much more. So Mallory-Weiss and all is just a little bit of blood at the end of vomit. So not even like half a teaspoon. That's not going to cause black tarry stools, right?
So the first thing is that this tarry stool means there has been a contact with acid in the stomach. So it has come from our stomach. Whether it has come from esophagus and gone to the stomach, but it was exposed to acid in the stomach. And what do we make out of all this? We are confused, right? So this host must never be normal prior to Thanksgiving. That's where you start guessing. We have done this in every Thursday. That make sure whether he was really well. And even today we use the term apparently well. This host cannot be normal. There is something abnormal with this host. What abnormality we have no idea at all. But this is an abnormal host, whatever the reason, and now get some bleeding without apparent inflammation. What does it mean? When there is no apparent inflammation, it could be a chronic inflammation or no inflammation. Even chronic inflammation does not give you symptoms of acute inflammation. So either we are dealing with a chronic inflammation or we are dealing with non-inflammatory problem. Chronic inflammation could be infective or non-infective inflammation. So we start thinking what it is. That's how the vomiting is the first symptom in this child because it's irritating the gastric mucosa and causing vomiting. But it is not vomit blood. Okay. And to that extent, whatever tarry blood has occurred has already started going down, and then thereafter he passed on. But thereafter he stopped passing with tarry stools, and there was streak of some blood, and that's fine. So the other thing that you must learn is every symptom, origin, duration, progress. We haven't seen the duration, yes, but we haven't heard the progress. As I said, whatever you written is progress, tarry blood, tarry stools. Okay, thereafter some streak of fresh blood, and thereafter no blood. No blood. So, what does that mean? Similarly, vomiting. Did the vomit stop after some time? When the trouble from the stomach descends down, vomiting stops. So has the vomiting been continuous for 20 days?
No symptomatic improvements in last 20 days.
So then we are not sure about this at all, what's really happening on this child. But one thing is sure that this child was always abnormal. What abnormality? must be malnourished. Why malnourished? We will have to decide that. And if you say that the mother said there were no symptoms prior to that, then it is a nutritional deficiency and malnutrition, and not secondary malnutrition due to some primary disease. So we start looking at this as a primary malnourished child. Now, what does a primary malnourished child get? Must be a severely malnourished, not only mildly malnourished. So if it's a severely malnourished child, then a GI tract has a multiple etiologies of a pathological problem. One is malabsorption. So there could be loose stools, gaseous distension, abdominal pain, whatever. The second is excess of bile that is irritating the intestine. You have said that there is some greenish stool, excess of bile, starving child. Okay, or increased peristalsis. That's why the bile is coming in the stream. So bile is irritating the intestine to further loose stools. So you have already malabsorption, you have a bile acid irritation. Further, a severely malnourished child tends to get immunological disorder. Why is that? Why immunological disorder in a severely malnourished child? Any thoughts? And the reason is our normal intestine does not allow a full protein, which is not broken down, to get into the bloodstream. Only when the full protein gets into the bloodstream that you have an allergic disorder. So this cell is not digesting as well. And then finds the entry of, so could be inflammatory. So you have inflammation causing bile acid irritation, malabsorption, and then on the top of any infection. Multiple etiology of this syndrome. We cannot differentiate one from the other. And this is what is happening with 4 types of pathogenesis of this diarrhea. You don't expect improvement at all. It takes time to improve. And more you starve the child, more you are harming the child. But more you feed the child, you are also harming the child. Add to that antibiotic, further worsening. This is what must have happened, right? This is what I guess out of this. Then you have a bilateral edema, obviously a hypoproteinemia. Okay, out of all this that is happening. But baby must be hypoproteinemic to begin with, and all this has worsened. Therefore, within a short period of this onset of problem, you have an edema coming. And I think that is the analysis so far. We have no idea which of these multiple possible pathogenetic factors are operating in this child. Therefore, the first thing learned again and again that this child, how well he was prior to this. Now, how do you find out how well this child is? They will say, "Aisa to theek tha." What do you mean, "Aisa to theek tha"? Khilta tha, sota tha, khana khata tha, bhook lagti thi. That is not all right. So, what question would you ask to make sure that he was really all right? Would you give a try to that?
The child is active and actively taking pills, oral acceptance, and weight gain.
Good. Anything more? What is more striking to a child who is not getting enough nutrition is the behavior of him. He is irritable. He is cranky. Because of temper tantrum. Okay. Then if he has mainly the protein deficiency, then he becomes lethargic. He's not interested. But he gets irritable on disturbance. So he is irritable, but sometimes he is lethargic, disinterested. Behavior disturbance is important. Then, of course, often loss of appetite. This is what parents would observe. Weight, it's unlikely that they would have ever taken weight. Why am I so sure? Only immunization up to 3.5 months. So socially not aware for whatever reason. There may be difficulty in reaching a vaccination center. There could be time spent, so there is no time, whatever the reason. So socially, this child has been disadvantaged. Therefore, you can add on further, there must not be hygiene, there must not be knowledge of what is good feeding, bad, and that is obvious with your dietitian. But mainly breastfed, little dal water, little dal. So ignorance, poverty, multiple reasons. All of that is coming up here. So we are dealing with a severely malnourished child with multiple pathogenetic factors and chronic. Therefore, will not get it. So now the question is, has this baby getting an outside protein, animal protein? So some animal milk, maybe something more. So that would further add to that. Vegetable protein is not likely to cause any further allergic response. Right?
But I thought this is just a nephrotic syndrome. No? The edema started from the lower limbs and it has gradually gone up and involved the whole body. So what's the problem in calling it nephrotic syndrome clinically?
Typical. It works in our hand.
No, so is that sacrosanct that it has to be periorbital? So can a nephrotic edema not come in the lower limbs first? So you have to think carefully and argue why.
Use the right adjective. Nephrotic syndrome is defined acute onset. This is not acute onset. Fine. So it cannot be nephrotic syndrome. Okay. Could it be protein losing enteropathy? Something like a nephrotic syndrome. The closest is protein losing enteropathy.
Not more than ascites, so protein losing, he couldn't have lost all the protein in one gastrointestinal illness, no? So you would have had history of repeated diarrheas or whatever in the past to give you that background of losing protein each time.
Background of malnutrition is already malnutrition.
Exactly. So that's what we are trying to tell you. So first thing is that in the exam, you might be tempted to go towards nephrotic syndrome, but you have to identify that this is not acute, this is chronic. See, you know that even illnesses can trigger nephrotic syndrome, relapse of a nephrotic syndrome. So that's the distinction we are trying to teach you. This is also an illness which has triggered edema in this child. But this is not a originally normal child, which usually a nephrotic is. And that edema is acute, this is not acute. So this is the difference. Okay.
Why does nephrotic not occur in a malnourished child? It's always a healthy child, right? Happy child, healthy child. What is this disease which affects only happy and healthy child? I'll give you a clue. Does asthma upset the nutrition? Why? It's episodic. Right. One reason. Okay. So nephrotic is not chronic. And if it's a chronic nephrotic, then it is not severe edema, but keeps on happening. Some varieties of basal chronicity. And to that extent, largely, sick child is never a primary nephrotic syndrome. But could a nephrotic syndrome occur in a sick child? Well, secondary nephrotic syndrome. SLE can come with nephrotic syndrome because of SLE, the child is sick. So the idiopathic nephrotic syndrome, primary, is a healthy, happy, comfortable child, but Secondary nephrotics are not. But this is not an age for that nephrotic. Okay. The nephrotic come primarily for edema. This child has come out with edema much later. So onset of a nephrotic syndrome is edema. And here the last symptom coming up is on edema. So multiple reasons why. Lastly, protein losing enteropathy is not a diagnosis. It's a kind of an intestinal pathology where you are losing mainly protein, but you're losing everything else also. But mainly proteins. Whereas here, he seems to be losing everything as far as what we know, and more blood. But don't you think when he's losing blood, he's losing protein? Blood has proteins. So anybody who is losing blood, is he not losing proteins? So what is this protein losing? Anybody who has a lot of blood in the stool is a protein losing. And therefore, the protein losing is really an excess of protein lost selectively. Okay. And after all, blood contains how much? In a malnourished child, it could be 3 or 4 grams per cell per 100 ml. Okay, you are not passing 100 ml of stool, so you're not even passing 1 or 2 grams. So protein losing is really losing every protein that is going inside you, right?
Since we started a little late, we won't discuss the negative history, but we'll go on to the feeding history because we want you to, so exclusively breastfed on demand, 7 to 8 times each feed lasting around only 5 to 6 minutes. And 6 to 7 times in a night time. So, how does this convey adequacy or inadequacy? So, my question is, minutes of feeding, is it related to adequacy, inadequacy? Yes or no? So, how much does a normal baby feed in the first month and then later and things like that?
Age of the child, so it will take 15, 20 minutes more. But once you go older, each bit will last more than 10 minutes.
So initially 15-20 minutes may be per feed, but later the time reduces. So the time is not really a marker of adequacy or no. So what is a marker of adequacy? Very good. So in other words, the contentness or satisfaction of the baby is the most important marker. Okay. Even the urine and all number of times of urine and all is applicable only in the first few days. Later, that is not the strict criterion. Similarly, weight gain. So you see on the growth chart, you have a wide band. So there are many possibilities of different amounts of weight gain. So contentment of the baby is most important. So in such a child, when you're suspecting inadequacy, what should be your questions to the mother? Or how will you know that this baby is not getting enough milk?
How long is the baby sleep after feed? Did the baby become time crying? But the night passing.
A hungry baby keeps wanting to feed all the time, again and again and again, and is not happy, as you said, so is irritable all the time, right? So that is what you will check. Then, what about the complementary feeding? Does this look good enough, not good enough? What is the problem? So you're
Okay, immediately after contact with the while they increases, we have to increase the number of people.
Yeah, so you have to increase the food groups, but you have to also ask about quantity. Now, dal water so is 0 calories, but mashed banana, but how much? So this is a very common problem. Parents will come and tell us sab khata hai, but how much? Just one morsel. So sab khata hai, one morsel is not good enough. So you need to ask about quantity. So that's how you come to know that this is inadequate.
I think you wanted to know adequacy. So you have said after 5 minutes, he puts the baby to another breast. Your first question would have been, do you decide that or your baby decides? Okay. For all that, she thinks that every 5 minutes you should change the breast. So my question to you is breastfeeding only on one side enough? Yes, it could be enough. Okay. Often you need both the sides, but occasionally one breast can secrete enough. Okay. Then why is the body given two breasts? And the reason is that within a short time or within 2 hours, the breast which is emptied may not fill up again, and therefore I advise to such a mother who tells you that my baby is happy with one breast, you say next time start with another breast. And the routine is you start with the left side, go to the right, next time start with the right and go to the left. Why is that? Fair proportion to both the breasts. Each breast must be emptied fully to refill again. So if I started with the left breast, went to right, right was half. So right has to be emptied to refill again. That's why. So I could have asked this mother, you decide 5 minutes. The baby decides. The baby decides, how do you know? You're putting it on the other side. So is the baby getting tired? Therefore leaves the breast. The mother feels the baby does not get enough. So put on the other side. Again, 5 minutes, goes to sleep. Is this baby weak enough not to sustain exercise or breastfeeding? It's not. I think this is the way. What we have been saying, history is thought in action. Unless you think, you don't know what next question to ask. Otherwise, they are taught like a robot. Okay, vomiting, yes, as usual, aggravating factor, relieving factor. Then you are a new, having completed history. Think what it is. That would have told us whether this child is really not even adequately breastfed. On the top of it, hardly any complementary feed. What should happen? But the milestones are not too bad. We are discussing, okay, gross motor look reasonably okay. Looks quite not fitting in well. We are looking at a severely malnourished child. And if the gross motor milestones are normal, then I start wondering, no, my assessment is wrong. One of the two are not complementary with each other. You just get to all these details. Your parents must have told you all that. You have taken it down, but you have not analyzed to ask her for the what you think, right?
So summary, 1 year, 2 month. 1 year, 2 month-year-old male child brought with the complaints of vomiting, blackish loose stool, followed by generalized edema, with a history of outside food consumption, with faulty feeding habits. Practices is a birth and development normal. Partially immunized is a case of acute dysentery.
So better summary would have been that you would have said that history suggests that this child was not absolutely all right earlier. dietary history suggests inadequacy, then this illness has triggered off or has made the hypoproteinemia manifest, and that is why this child has developed edema now, right? So it was a malnutrition which was just waiting to be exposed, the hypoproteinemia. Baby is already malnourished, right? Give us the
It's all right, I'll consider, I'll do. Gives their hypoproteinemia. Can the history differentiate primary nutritional from secondary causes? Because that's the next step. If you're sure it's primary nutritional or it is social factors, ignorance, whatever. But if it's secondary, then we need to find out what's the secondary cause. I'll give you a clue. Nephrotic syndrome is the severest form of hypoproteinemia you have seen. Cirrhosis of liver may not be that severe, but severe enough. Okay. And then comes the protein malnutrition, which is not so severe. Albumin is less than 1 gram in nephrotic, maybe less than 2 grams in cirrhosis, and maybe 2.5 or almost 3 in PL. We don't divide according to this. I'm just giving you an idea. So higher the protein loss, and here PL not so higher. What is the difference in the history? The PM child, as I said, has a behavioral abnormality. Okay, but nephrotic who is losing lot of proteins has no behavioral abnormality. I thought behavior is because of severe hypoproteinemia. Isn't it? Kwashiorkor or another behavior severe. But nephrotic is much more severe. Cirrhosis of liver is much more severe. He doesn't have hair changes, skin changes, mental changes. No. Why is this different? Any idea? If this child's history suggests that he had some mental hair, whatever, then we know it's primary. Okay. Parents may not have noticed all that, that's missing. Examination might notice. But why this difference? Nephrotics being severe have no mental hair, skin changes.
what are proteins made up of? Any difference in that? What are the types of amino acids? So what is the meaning of essential and non-essential?
But it's not.
Very good. So nephrotics are losing albumin largely, or sometimes even oil. After protein has been digested, amino acids absorbed. Therefore, PEM is not a protein deficiency, but an amino acid deficiency. But it comes from protein, so we call it protein. Whereas the nephrotic and cirrhotic are not amino acid deficiency. After digestion, absorption of amino acids, we are losing protein from the body pool of protein, right?
Let's examine.
On examination, child is active, alert, conscious, febrile, heart rate of 152 per minute, regular in rhythm, respirate of 23 per minute regular, saturation 97% on room air, extremities warm, capillary fill time less than 3 seconds, pallor present, bilateral pitting edema till knee, upper limb and edema in upper limb and periorbital edema. There is no signs of dehydration.
But look at disparity between heart rate and respiratory rate. Respiratory rate may be little less than expected. And the heart rate tremendously fast. Something unusual, right? So either respiratory muscles are weak, rate is low. Okay, or there is a heart disease. How do you interpret this? Give a thought. See, at the postgraduate level, we are not going to ask you the diagnosis in this. whatever that is. They don't ask you the interpretation of minor things. So if you found 152 and 23, to an examiner, you should say 130 and 35. He's not likely to count, but if you tell him the truth, you are in trouble. So sometimes you may have to play a trick. They're not teaching you to play a trick, but when you are confronted with a problem, you must solve the problem. Okay, because you have to pass. But now tell me, is it the respiratory weakness, more respiratory rate, muscle paralysis, hypokalemia, and children are more hypokalemic? They have a muscle weakness, they have a respiratory muscle weakness, or is it the heart? Again, hypokalemia, so heart is beating fast, myocardial muscle is damaged. So what's your, so point is, unusual finding, check again. Okay, but if it's mainly cardiac, then there must be anemia as a significant problem. That's why heart is taking care. Okay, and that's the first response of the heart to increase the rate. But disparity should make you know that, let me check again, or then let me find the time. Just to ask you, if the respiratory muscles are weak, would there be lower respiratory rate or a higher respiratory? So shallow and maybe be rapid to begin with. Thereafter, when the respiratory center is failed, because you have tired muscle, that means the respiratory failure has started. Then you can have any kind of thing. So you should have a rapid and shallow. If this was a pterygic respiratory muscle, right? So,
Oh, sorry, sir, that is actually a typing error, respiratory. Then on anthropometrized child impression is weight which is 8 kg between -3 to -2 standard deviation, height of 74 centimeter between -2 to -1 standard deviation, head circumference 45 between -1 to 0 standard deviation, mid-arm circumference between -2 to -1 standard deviation, and weight for a height between -2 to -1 standard deviation.
so weight is reasonably fine. Weight is reasonably fine.
Age is 1 year 2 months due to edema ongoing.
How much must be edema contributing to weight gain?
20 to 30% of the original weight.
No beauty. Dehydration, you know, first degree, second degree, third degree, 5%, 10%, 15%. What about edema?
Sir is asking, how do you judge how much weight is contributed by the edema? So now go backwards. How much weight is lost if there is dehydration?
That you know.
Revise it. How much weight is lost if there is dehydration? So in infancy, 5, 10, and 15%, and older children, 3, 6, and 9%.
So roughly that is the solution.
So edema also roughly you would reverse it that way. So mild, moderate, severe edema, right? So, I mean, again, just to check, what all is abnormal in this? What I want to tell you is that -2 SD to -1 SD is normal. It is not abnormal, though it shows minus. So literally, except for the weight, nothing else is abnormal in these statistics. Okay? And in the weight, because it is 8 kg and let's say 10% we say is edema or whatever, 59 to 15%. So the actual weight of the child must be 7 kg. Right?
That suggests that the problem may not be as chronic as we thought to begin with.
Grade 2 examination, there is no facial dysmorphism. Periorbital edema, more on the right side, has come to left, secondary to the positional, then hand edema, bilateral pitting edema till knee, pallor was there, skin, hair, nails normal, spine normal, genital pubis swelling and mid-penile shaft swelling. On per abdo inspection, on inspection mild distended, no flying fullness, no scar, sinusal dilated veins, umbilically centrally placed. On palpation, inspect findings confirm, no local rise of temperature and tenderness, liver of 1.5 centimeter, palpable, soft, smooth marble, rounded margin. There is no spleen. On percussion, tympanic note all over the abdomen. On auscultation,
That patient is this patient.
yes. Auscultation bowel sound heard. Severe S1 S2 present with gallop and tachycardia was there. CNS child is conscious alert. On RS examination, air entry, bilateral chest clear.
Okay, you complete this.
So my impression is 1 year, 2-month-old male child brought with the complaints of vomiting, loose stool, and followed by generalized swelling with history of outside food consumption, with faulty feeding technique, feeding practices, with pallor, on examination with pallor, hepatomegaly, who is birth and developmentally normal, partially immunized, and anthropometrically mapped, is most probably a case of uh, acute dysentery with severe anemia in a failure, most likely nutrition secondary to faulty feeding habits.
क्या है ये?
Crying, we will let it be in mother. Yeah. The letter.
आप यहाँ बैठो अपना बोलेगा मुझे फिर ये कुछ नहीं करता बेटा कुछ नहीं करता
एक बार ये वन AC for the time.
ये नहीं
Please say what you can see on observation. No. Huh? So whether irritability or what happened, then periorbital edema, then pedal edema. Is it there on both legs? Then pallor, very good. Then you think there is abdominal distension? No. Do you think it's tachypneic? Where are you looking? Very good. When you look at the abdomen, you can make out it's slightly tachypneic.
Because hair changes, right? Hair changes. Yes or no?
So what changes you are looking for and what is there here? One is easily pluckable, then lusterless, dull, in brown color. So is this brown? No, they are sparse. So it may be that one of the criteria has been fulfilled. So how do you check that? We wanted sparse hair, no? And you got sparse hair. But you should always ask one question. What is that question?
Has the hair been always like this?
Ask.
Okay.
बाल ऐसे ही पहले से
I see.
Not due to hypoprotein.
It's pretty common in an examination to get such a thing. Okay, examiner will get you on to say it's abnormal. As the parent, I will say yes, I have. Okay, so that's normal. Okay. I think what is striking is fairly nourished. Okay, so that ma'am, etc. is not fairly there. So now we need to get back to the correct history. Okay, history suggested, diet suggested, but the findings don't suggest. So would you believe the findings or would you believe the history? Remember, what you see, you believe, or what you have heard, you believe. I think it's obvious that he has done well. So whatever the diet history is, that he has done. खाना खाता था बराबर ये बीमार होने के पहले
बीमार होने से पहले खाता कुछ नहीं
ओके थोड़ा पतला पतला चावल दाल खिलाते थे खिलाते थे चलता है ना खड़े रहता है खड़े रहता है पकड़ के चलता है
नहीं चलता
खड़े नहीं रहता पकड़ के
खड़े रहेगा
अच्छा
ज्यादा टाइम खड़े भी नहीं रहता
It looks like a recent onset disease. Looks like he has not been malnourished earlier nor now. So the history was quite misleading. Okay. क्या खून बहुत जाता था क्या संडास में खून जाता था
खून नहीं देखा मैंने
खून नहीं देखा
काला सिर्फ काला काला देखा था
अच्छा तो काफी काला काला जाता
हाँ
था
5 दिन तक बहुत लाइक
अच्छा इतना काला जाता था तो वो बंद हो गया
से दवा लेना फिर
और जब ये काला काला जाता था तब ये रोता था क्या नहीं ये तो खेलता था
हाँ रोता था पर
क्या इसको पेट में बहुत दर्द होता था
दर्द
नहीं it was non-inflammatory bleeding maybe of some other etiology. Okay, yeah.
That must be iron tonic.
Yeah, could be.
दवा चलो
somebody
कोई
there.
काली
Yeah.
कुछ भी नहीं
ठीक है अभी पहले से ठीक है ना तो खाकर सूजन निकल जाएगा उसकी चिंता नहीं संडास कैसे होता है काफी समय पहले
मतलब अभी तो हरा हरा कर रहा है पर वैसे पतला कर रहा है
भूख लगती है कर रहे हैं
हाँ, भूख लगती है
तो खाना खिलाते हो तुम
हाँ ज्यादातर केला खाता है
ठीक है लेके जाना अभी ठीक हो जाएगा ओके टाटा करो बेटा टाटा करो टाटा करो
टाटा करो
ये बड़ा
टाटा करो बाय बाय
नहीं टाटा करो
टाटा कर लो नहीं अच्छा कोई बात नहीं Obviously, findings that you have seen, you would believe them more than the history. Okay, so I think again, what I'm trying to say is that many times history is not reliable, but why the mother is reliable, but what she gives is not reliable. That is because you don't ask reliably the history. That's why it's not reliable. Mother always knows the best. Only thing is, your way of asking conveys her something different, and she gives a different answer, right? So I think what we are learning is that many times it was good that you brought the child, and we could see totally a different story. Okay, as if story of acute illness was more right. We don't know why that, but that blood in the stool or tarry blood was unaccompanied with any significant pain. So it was non-inflammatory. So it must have been some blood vessel, stream, whatever. We may have to see whether there's any varices sitting there. It's absolutely unlikely, because there's no reason why there should be varices there. Or iron given, but not large amount of carried value. Little black colored stone, yes. So again, we are not very sure what made the shell bleed like this, but non-inflammatory bleed, that's what we started saying. Good, I think not a learning point, but more important to learn it. History taking is not an easy job, and we have to dig in to confirm that what you are saying is the only right thing to do, right?
Investigation. AFTs are within normal limit, OTBT, then RFTs within normal limit. Total protein of 3.5 and albumin 2.1. Electrolytes normal. Serum iron of what 222 and iron binding globin 196.
Comment on this. Serum iron 222 and iron binding 196. So what is your comment on this? Normal or high serum iron? High. Why is it high? Because his iron, his pale body is absorbing too much. No, that never happens. So why it is making it high? Usually this kind of a level means that he has been administered iron orally, whether recently for a long time. No, she is denying any medicine given, iron medicine given. So then we have to think whether this is one of those disorders on the anemia front where iron is not being utilized. So refractory to iron, whether that is one of the reasons why this child is pale. You have to think of that. Then RBC micro hypopolychromasia
Aniso.
and
Aniso.
aniso. Hypersegmented neutrophils. What does that mean? Could be megaloblastic, so B12 deficiency. So we'll have to think of that. RDW is 19.9. Go. Urine routine, normal.
Wait to be tested.
Oh, right.
Thank you, sir.
Next tool will. That iron is funny. We need to repeat the iron, I would say, and check again and then decide on whether it's one of those iron refractory states.
Hello.
Boy, second by road order, born out of non-consanguineous marriage, resident of Kurla, hailing from Junior, Hindu by religion and Maratha by community, brought and informed my mother with a complaint of breathlessness since 1 week. Child was apparently ordered 1 week back, after which I started having breathlessness and 3 days in onset, increased on exertion, gradually progressive and relieved on rest. Child was able to perform normal routine physical activities. It was associated with chest pain, retrosternal location, increase on exertion, and associated with palpitation. There was a history of easy fatigability, history of paleness of the skin as noticed by the mother, history of fever, cough, and cold 1 week back, taken symptomatic management for it, and it was relieved. There's no history of decreased appetite, weight loss, no history of passing worms in stool, no history of abdominal distension is present, no history of blood loss from any side, no history of blood transfusion in the past, no history of pedal edema, no history of any bony pain, no history of jaundice or pain in abdomen, no history of similar complaints in the past, no history of COX or COX contact, no history of decreased urine output, no history of melena or hematemesis, no history of similar complaints in any family members. For the above complaints, child was taken to a local practitioner where some blood investigations were done and hemoglobin and platelet was told to be less. Past history, there is no significant past history. Antenatally, it was registered in a book case at the private hospital in Pune. IFA tablets were taken, ANC scans were normal. There is no history of blood transfusions or hospitalization during the ANC period. No history of any comorbidities during pregnancy. Birth history, it was a full-term delivery. LSCS was in view of previous LSCS. Birth weight of 1.5 kg. The mother wasn't sure. Baby cried immediately after birth. There was no history of an ICU stay. No history of neonatal jaundice. Postnatally, the child was breastfed after 1 day. Mother received blood transfusion post-delivery in view of anemia. The details are not available. Immunization, the child was immunized according to, till the date, according to NIS. Developmentally, the child was normal. Dietary history, there was a calorie deficit of 250 kilocalories and protein deficit of 6 grams. Family history, no history of illnesses in the family. Socioeconomic history, the child is an elder brother who is 13 years old.
Go to the first slide. In the second slide, will be the second. 8-year-old child. No?
Yes.
So look at the first paragraph and then first tell us whether the anatomy is the respiratory system, the cardiovascular system, or the hematological system. We'll discuss these three as the anatomy possibly. So whatever comes to your mind, pros, cons, this is going in favor of this, whatever.
I think cardiac onset, the cause of breathlessness, because it's increasing on exertion. There is no stress at rest. It improves on rest. And there is associated chest pain also.
So when it is on exertion and when it is relieved on rest, out of these three anatomies which I told you, respiratory, cardiac, and hematological, does it rule out anyone? Why?
Risk also the history.
So therefore, it makes respiratory less likely. So now you are between cardiac and hematological. No debate between these two. What will you discuss or debate?
Rules out like congenital heart diseases as the point.
Don't go that way, whether it rules out congenital heart or not. The whole crux of the matter is, was this child absolutely all right 1 week back? That is extremely important to deciphering this further, right? If so, then how would you debate? Suppose assume that this child was absolutely all right. Then how would you debate between cardiac and respiratory hematological with a 1 week breathlessness? So which hematological condition will become breathless on exertion overnight?
Hemolytic process.
So acute hemolysis and that too severe, or blood loss. You have to have a massive hemorrhage. In which case will they present with? Yeah, they'll present with that bleeding itself. Okay, so breathlessness on exertion is not a presentation. So that is a presentation if of anemia. It is towards the more severe anemia, and that can't happen overnight. And if it happens overnight, there has to be many other symptoms. So that thing about being absolutely all right 1 week back is very important. And then we have history of cardiac also and anemia also. We have got history of chest pain, we have got easy fatigability, we have got paleness of skin. But paleness of skin noticed when? Noticed now in these 8 days, earlier than that, now in these 8 days. What do you make of that? Acute hemolytic process. If it is acute hemolytic process, take it further, ask more questions. Acute hemolytic processes are of two types: intravascular, extravascular. What questions will you ask? Passing red colored urine? No. Extravascular acute hemolysis? Jaundice. There's no jaundice, there's no pain. So it doesn't fit in with acute hemolysis really.
I think look at the second line. You have said that child was able to perform routine physical activities even when he reported breathlessness.
So breathlessness is only on exertion.
So only on exertion. Now, routine physical activity. What do I mean by that? When you feel breathless on accustomed exertion, it's pathological. Okay. If I can normally come up my staircase here, and I don't feel breathless, but nowadays I feel, then it's abnormal. Okay. But if I have to go up 4 stairs, I will be breathless. So this might mean to me that he is not really breathless on accustomed exertion. He could be breathless on unaccustomed exertion. Okay, that's important. And if it is so, then it suggests chronicity of the problem. Could it be a chronic heart? That's the next thing. Okay. When the mother has reported pallor, it must be severe. Okay, normally they won't report a moderate or mild pallor at all. Therefore, when parents come out with history of paleness, it is almost always hematological till through the line. Okay, everywhere there is a catch in every statement that I make. but mostly hematological, less likely any cardiac. But anemia can affect the myocardial, so that part, palpitation, etc., whatever, could be secondary to anemia. Could it be a mitral stenosis? Typical story. Established mitral stenosis. Okay. Back pressure, pulmonary venous congestion. Okay, not arterial. So venous congestion, so breathlessness on exertion. Why not a mitral stenosis? So again, we go back to that paleness. Okay, why should an 8-year-old with mitral stenosis reporting paleness unless this child has also severe deficiency anemia and also has mitral stenosis? That means two diagnoses. So to fit in one diagnosis is hematological. Examination might show two diagnoses. Okay, that you can't pick up in the history itself. Now, if it's an anemia, then what kind of anemia? 8-year-old, no past history of transfusion, no genetic story of anemia. So must be a deficiency anemia. Okay. So if you're thinking about deficiency anemia, ask two questions. Has there been an abdominal distension? If it's a hemolytic anemia, there will be an abdominal distension. That's number one. Second is also correlate with a poor diet. Diet poor in B12, two together would make it deficiency anemia. But it's chronic. Why not acute? Anemia could be acute, no? So is this acute anemia or a chronic anemia? On the history?
No.
Acute? Why?
Chronic will be compensated, you will not be having other complaints. I don't notice pain.
So he is fairly compensated. He is doing his routine activities. Only when he exerts, he gets it. So it could suggest that it's reasonably accomplished. It's severe anemia. But in spite of severe anemia also, he is able to do routine activities, which suggests a compensation. Had it been an acute one, then he would have been much sicker. Okay, acute anemia with severity. That means severe hemolysis or a severe hemorrhage, okay, or a severe bone marrow suppression. All of them would have been sick. Okay, acute hemorrhage would have been in shock. Acute hemolysis would have been in jaundice. So acute bone marrow would have been sick. That is not seen. So maybe it's a deficiency anemia. Okay. Suppose it's not, and now we find abdominal distension and spleen. Then we move to hemolytic anemia. Which hemolytic anemia becomes severely pain at the age of 8 years for the first time?
Acquired.
Acquired. Acquired is chronic or acute? Often acute. So jaundice. So again problem. Okay. So then the question is, which congenital hemolytic anemia would come for the first time at 8 years old?
Or rephrasing the question, can come for the first time at 80. Congenital hemolytic.
One anemia, hemolytic congenital, which can present at birth or may present in old age for the first time, spherocytosis. And ask one question in the history to tell me spherocytosis. One of the parents must have spherocytosis. But what question do you ask them, do you have spherocytosis? They will say, we don't know, we don't see the doctor. Then what question? Short stage. If father or mother, one of them is short, then it could be familial, it could be genetic, yes. But a short stature and looking moderately pale, she has gone through pregnancy, the mother, she might tell you, मेरा hemoglobin तो साथ ही रहता है, तो कितना भी दवा दिया कुछ फर्क नहीं पड़ता. So she's short. So you know that she could have spherocytosis. and one examination finding which tells you which cycles. Numbers. Too simple, no? Right. Let's see what she has to say. Okay, we made it simple. Medicine is not that simple. So we will start making it simple and learn the complexities. Now the last point is fever cold of 1 week. That might have aggravated the parents' attention to this parallel. Okay, that's why they say take up the second. They saw it in this 1 week. Right?
Eight-year-old boy immunized and developmentally normal child is likely a case of anemia presenting in failure, differentials being hemolytic anemia and hemolysis. The child had
Two
thrombocytopenia.
diseases that you have given are too wide apart. It's like saying that he's mentally retarded, but came first in the examination. What is right? They're all candidates only for delay development people, in which he came first. Really? He came first and he had delay development, but two things don't go together, no? So what is common with dengue and hemolytic anemia? Please give a thought. She has put two together. Okay. So that makes us think, is there anything common? So does dengue often have pallor? Or do children with pallor often have dengue? Let's discuss that. If not, then those two things are not together. Give a thought, doesn't matter, because see, everything that she puts up, we can start thinking. Okay. She has put two together because she has diagnosed both. Okay, she has an indisponentism also, and she has got a hemolytic anemia also, maybe. Okay. So can dengue have a severe anemia?
After hemorrhagic shock and bleeding and all, maybe there is anemia. But by then there will be so many manifestations before, right? So what is your analysis in calling it dengue-like illness? In
The
clinical,
child had history of fever.
you said you wrote no abdominal distension, but you said there is history of abdominal.
Abdominal distension is on asking, like if I ask and the mother is like, she did not say it on her own.
Okay, but again, so see, these are important. No? You should then qualify a cup say. If the whole illness according to you is just 7 days, then when did that abdominal distension come up? What I'm trying to say is, if you would have given a story of fever, cough, cold, after 3-4 days, fever got better and child developed abdominal distension. If this is the sequence of events, yes, dengue does come in, and then you ask for other corroborative history. The child was vomiting, had pain in abdomen, became lethargic, all that, right? So, is that anything like that? No.
But I feel she is right. Because dengue is caused by mosquitoes. Anemia is also caused by mosquitoes. Malaria. Okay. If I am among the mosquitoes, they're not only dengue mosquitoes. Okay. So are there dengue mosquitoes and some are malarial mosquitoes? How do you recognize them? Looking at them or examining them? So typically, malaria holding parasites are in the dirty environment, dirty water, and the dengue is in a clean. So invariably, something can be either clean or dirty, but not at the same time both. Therefore, at some places, malaria is more common at some. Of course, everything is clean enough, but also dirty enough. So we see both in our case.
Go on.
General examination, blue third color, right comfortably supine. Heart rate of 144 per minute regular, normal volume bilaterally equal palpable pulses. RR of around 30 per minute regular. Saturation was 98% on renal extremities are warm, peripheral pulse is well fed, central pulse is well fed, CRT less than 3 seconds. BP is 100 by 70, around 50th central in the right upper arm in supine position. Pallor is present, no icterus, clubbing, cyanosis, lymphadenopathy, and edema. And throughout the child is
There is only one plus, no? This was there, no, only one plus. That means the mother must have reported shock. That's why the child was looking there. Correct? So must be there. No comment. Shock is paleness, no? Then we thought paleness is anywhere. No, shock is also paleness. You must be in shock, right? No, there is nothing else happening, right?
And throughout the shallow family, weight of 28 kg, length of height of 128 centimeters, and BMI 17. Height to examination, hair is normal, eyes and ears are normal, knuckle pigmentation is present, spine is normal, chest is normal, genetic is also normal.
You
Systemic
said air sparse and easily. What is that easily? Easily sparse, or you wanted to say he's very flexible?
the typing.
Typing error.
I thought you were telling us take it easy. All right, doesn't matter.
Per abdomen inspection, shape is normal, distended or uniform, umbilicus is inverted, flanks are not full, all the regions are moving equally, palpation, inspective findings are confirmed. No local rise of temperature, no guarding or rigidity. Liver is firm, rapidly 4 centimeter within the coastal margin, moves with respiration and it is non-tender. Spleen is firm, 6 centimeter palpable, just up to 24 umbilicus, moves with respiration and non-tender. Percussion confinement no is heard. Liver span is 15 centimeters. Auscultation bowel sounds are heard.
Yeah, I got a diagnosis by the previous slide. It's cirrhosis with portal obligation. Okay, the last thing, you got a firm liver. Therefore, you must have had bleeding. Okay, microscopic continuous bleeding. So it was clear. Perfect story. Okay, some liver last bleeding. Okay, not hemolytic anemia, cirrhosis was given. What more do you want? We are fighting why only mild color. Okay, yeah, so maybe lost some blood, but I said maybe lower down up or whatever. I think classical story of cirrhosis.
What other manifestations of liver failure?
Right.
Poor growth, jaundice, and
What is a growth? Growth is good. So, no edema, many things, okay, yeah. So must be malaria. Clean liver, clean more than liver. Undergraduate, I was also taught. Clean more than liver, malaria. That fever, malaria. Okay, everything mentioned malaria only. Mild anemia, really, no hemolytic anemia.
Anything against malaria? There's no fever now. What else? The spleen is too big for malaria, and then why liver also? So all this thing.
Yes, S1 S2 there's no murmur. Respiratory, air entry bilaterally equivalent cleared. CNS the child is alert. Tone, power, and reflexes are normal. There is no meningeal sign. 8-year-old boy immunized and developmentally normal child is a case of anemia with splenohepatomegaly presenting in favorable etiology being hemolytic anemia.
So why are you saying presenting in failure?
The child had tachycardia or breathlessness.
on presentation, how much?
It was 144.
144. And
And
RR was,
32.
you showed us that. So that time you said pulses were well felt and BP was good and all.
BP was good. It was 170.
And even pulses you said were good, no? I think show us that slide again, your vitals. Peripheral pulse is well felt, CRT less than 3 seconds. So somehow these things don't go hand in hand with failure, right? And again, if you are saying failure due to pallor, then the pallor has to be quite significant. No? We just said mild pallor. So was it bad? Was it very pale?
No, child was good.
Go on.
I think pulse pressure is
Arrow.
normal, but with anemia, you would have expected a little high pulse pressure.
Then the HP of 4.4, hematocrit of 12.8. MCV was 84.8. MCH was 28.9. MCH is 34.3. WBC count of 4.5 thousand. And platelet count of 37,000. No child, transfuses child, 5.5 transfusion patient. This is the PS. There's no red big seen, but large platelets seen. The lab totally the LFTs were known.
Okay, go on.
With the whole life of the child, the glass
Acute leukemia. So you had said in the history that there was chest pain which was retrosternal. Now, again, that needs to be, you almost suggested a bony tenderness now, it fits in as bony tenderness. But we didn't get it as that chest pain retrosternal. You are misguided to think of a heart and all that.
But leukemia does not complain of retrosternal pain.
Yeah,
Leukemia is having a tenderness,
correct.
but not a complaint of pain. Unless you touch and press, there is no pain. So two things are a bit different. Okay. And more important is how sick is it?
So the child was not sick, presentation wasn't failed. After that, he was fine. And one day during the course of the war, he developed a carpopitular spasm. So the iron calcium was given.
So obviously leukemia from the history, so many gaps in the history, but I was just, I made you go ahead and I forgot to discuss that part. That if you were to just look at the liver spleen and the growth of this child, just based on that, what would be your thought process? So you have a big liver, a big spleen, and a normal growth child. And then typically we discuss that how do you approach this? So you look at the 4 parts of the liver and see which part it's fitting in. So what do you think of that? Is it hepatocyte dysfunction? No. Agreed? There's no jaundice, there is no symptom of hepatocyte dysfunction. Sir asked you chronic liver disease, there's no edema, there's no, so that is out. Is it biliary tract disease? Biliary tract disease has to have disease, so that is out. Is it venous system disease? No, there is no sign of neck veins or ascites or anything. So ultimately you are left with RE cell disease. So some infiltrative disorder, but we are not able to, extrapolate it to why the sudden presentation of, and that pallor also, you put just 1+ and you said hemoglobin was 4 and yet mother noticed pallor. So I think that's where we missed it, but possibly we could have thought of it as an infiltrative disorder
And acute infiltration.
which acute infiltrative will suddenly cause so much pallor and then.
Should have looked sick, basically. Okay, acute onset leukemia would be sick. So rest of it fits in all right, but greatness of an exertion is an unusual feature. Again, pallor is not severe, so that doesn't relate.
No, pallor, sir, she wrote 1+, but if the hemoglobin was 4,
Then it must be.
then must be quite a.
Again, leukemia with 4 grams hemoglobin looks very unusual. After all, leukemia is commonly a lymphatic leukemia or a myeloid leukemia. Okay. They are not pale and it's acute. Acute is never pale. Maybe deficiency anemia, 8, 10, whatever. So there are too many gaps in understanding it. Well, the reports have said it's leukemia, so we accept it.
Yeah.
But we will not go back thinking that leukemia presents like this. That is where we need to be sure of it.
Also, so that's one part, but also in exam means, how would you justify a diagnosis of hemolytic anemia? Also, you need to say when you give your differentials.
We said no, 8-year-old, first time hemolytic anemia without jaundice. No. Okay.
So hemolytic anemia is a difficult differential to explain.
I wasn't sure.
Huh?
I wasn't sure.
No, I understand we are learning. I'm just saying that when you present this case, so even if we go backwards and we were to present, I think our differential diagnosis, we would have had to come down to this analysis, what we said, that it's an infiltrative disease with severe anemia. So in fact, I was going through my mind of storage, etc., but that acute versus chronic, all those things come in,
I think retrospectively, I felt that you have a chronic anemia in the cell, which is deficiency, and an acute leukemia on the top. So we have a combination of 2 things. Okay. Now, chronicity is there, and anemia is so low. So chronic anemia must be deficiency anemia. On the top of that, we got acute leukemia. Clinically, large liver, large spleen is against all that we talked about. So, and good apparently good growth. Good growth is deficiency anemia. He is not malnourished at that age. So maybe iron deficiency or B12, whatever, and on the top we got an acute leukemia. I think whenever 2 things coincide, the history has to be tremendously in details to pick up 2 different things coming at 2 different levels. Okay. Anyway, I think that's a good presentation, and we could see what we were expecting was something different than what we got. But we still want you to tell us why did you put Deng also there? No, your first poster, so I can understand that. So learn to ask questions to us also and to your teachers also. Okay. When you ask me a question and I don't know an answer, I will tell you I don't know. But tonight only I will go and read it. Of course, tomorrow at my age I will forget it also, but that's different. But I will at least read it. So I will know what I don't know even at the end of all that. You must question us. I think good. That's all right.
नहीं,
Good. That's
I'll say it out. Most of your babies will have black knuckle. We miss that. Most of them have edema in their feet. We never see them. We never remove their underwear. Otherwise, we will also say that the first place to see edema is scrotum. But we never